am Dr. Mary Lou Harrigan, and I have had the distinct pleasure and privilege of planning many dialogue on aging programs over the years. Until recently, these were all held in person, and we strove to have a learning community that came together for opportunities to learn from researchers and clinicians, and just in general have a good, enjoyable learning time. As recently, as you know, because of the pandemic, we have moved to a virtual opportunity to carry on this learning community. And we hope that for the fall series that you will be joining us and enjoying and learning from our excellent speakers and discussions that arise from that. Today, we're particularly focusing on brain health, a very important topic for all of us. We welcome you from across British Columbia and also a few from outside, further afield in Canada. I would like to open with a few inspirational quotations. The first is from Maya Angelou. I have learned that people will forget what you said, that people will forget what you did, but people will never forget how you made them feel. A second also from her, and I think pertinent for the times in which we live. If you don't like something, change it. If you can't change it, change your attitude. And lastly, from a philosopher of old, Plato, good actions give strength to ourselves and inspire good actions in others. I wish you well and enjoy the session today.
At the end of each presentation, we'll have time for questions, and so please use your little raise your hand at the end of each presentation or the chat box as well. September is World Alzheimer's Month, and that's really a time when everyone around the globe are really focused on talking about Alzheimer's and other related dementias and what that means to us globally. And if we take that down to BC, where we are here today, we know that in British Columbia, there are over 70,000 people who live with this disease, and we know that number is growing. And the Alzheimer's Society BC really would love to have a country, a province without Alzheimer's. While we know that that's a long ways off, what we do believe we can do through our mission is create what we call a dementia-friendly province. And that is a place where people living with dementia, their care partners, friends, families, can live and be safe and acknowledged and still continue to have the quality of life that they want and that they deserve to have. And there are 5 ways really that the Alzheimer's Society of BC are looking to create that dementia-friendly province. The first way is we're trying to change the conversation, just like we're doing here today. We're talking, we're listening to people talk about their experience with dementia, sharing their ideas, whether that's from people living with the disease or from researchers. We really need to keep talking, keep the stories being shared. We want to change the experience. We want to ensure that people living with dementia and their care partners have the right support and services to help them know the way that they want to move along their journey. So through the Alzheimer's Society of BC's First Link program, our dementia helpline, we are ensuring across the province that people have supports that they can reach out to. We are changing the practice. We want to ensure that healthcare professionals who are supporting people on their journey with dementia have the right education, knowledge, information to understand how to better support people living with dementia and their care partners. So the experience for those who are receiving care and the experience for those who are providing care is the best that we can ensure. We want to change policy. We need to ensure that provincial government bylaws, legislation, as well as civic really are reflected on supporting people. We need to look at the bylaws and the policies to make sure people have that support that they need. And we want to change the future. We want to support research to look for ways that help us better understand what causes Alzheimer's, how can we treat this, what can we do to live with this disease better. But we know it's a tandem process. We know that while researchers are working really hard to learn that information, we need to continue to provide care. Both must go hand in hand. And that is why it is so great to have the two researchers who we have today, because both individuals, as much as being dedicated to research, they're dedicated to being a clinician, to serving patients, to putting people first. And that wonderful combination makes them such leaders in their fields. And researchers understand the importance of being able to talk to people and share what they are learning, but they also understand the importance of hearing from people and listening to people tell their stories so that, again, the two can come together and work. I'm really excited today to listen to both our speakers. But before I get to introducing them, I'm going to turn it over to Avery Milne and Daisy Couture, who are both from the Alzheimer Society of BC, who are going to share a little bit on how the Society is approaching dementia and research. Daisy, Avery?
Okay. Well, hi, everyone. Thank you so much for joining us today. So as Maria mentioned, my name is Avery. I'm the Provincial Coordinator for Knowledge Mobilization with the Alzheimer's Society of BC. I might look familiar if you tuned into the summer series along with this wheel here. But today I've also brought along my colleague, Daisy, who will go ahead and introduce herself.
Hi everyone, my name is Daisy Couture and I am the Research Program Coordinator at the Alzheimer's Society of BC. And like Avery said, today we're going to dive into a bit more how the Society engages with research, and then we'll get a chance to spin the wheel and test your dementia research related knowledge, and you get the opportunity to win some Society swag.
Yeah, so I'm going to be asking Daisy a few questions about research. So first of all, Daisy, why does the Society support research? Why is it important?
Thanks, Avery. Like Maria touched on briefly there, the Alzheimer's Society of BC ensures that people affected by dementia are not alone by mobilizing a broader community of care around them. And one of the ways we do that is by ensuring that there is research into the disease and people living with it. By 2031, if nothing changes, there will be 1.4 million Canadians who are living with dementia. And research is really key to changing this story.
Yeah, and so when you say research, what does this look like? Is it all done in a lab with test tubes, white coats, that sort of thing?
No, not necessarily. That's often a big misconception, but there's a lot of different areas of dementia research, as I'm sure we'll hear about today. There is research into the causes of dementia, treatments and cures, diagnosis, quality of life, and risk reduction and prevention. On the screen right now, you can see a couple pictures of examples of research. There is, social robots in long-term care, intergenerational choirs to help reduce loneliness and improve cognitive outcomes. And then there's also research into the biomarkers of dementia. And all of this research provides hope and improves the lives of people living with dementia. And so that's why supporting research really fits in with the Society's expertise and is also a really crucial part of our mission.
That's great. Thank you so much. So how exactly is the Society involved in research?
Yeah, so the Alzheimer's Society of BC supports research in three main ways. The first one is as an investor. We fund research through the Alzheimer's Society Research Program, which is a national funding competition that takes place every year and funds research across Canada. We also fund the Ralph Fisher and Alzheimer's Society of BC Professorship in Alzheimer's Disease Research at the University of British Columbia. And right now on the screen, you can see Dr. Robin Chung, who is currently holding that professorship. And then we also fund researchers here in BC. And then the second way that we support research is through partnerships. We partner with the dementia research community in a variety of ways. For example, we often act in an advisory capacity on studies. We'll help communicate the results of research after studies are done. And we'll also help connect people who are interested in participating in research with studies that would be a good fit for them. And then finally, we also are a knowledge source. So we provide information on dementia research on our website, in our 2 quarterly newsletters, and in our annual Focus on Research, which covers things like how to check if research that you've heard about is reliable, or what were the biggest dementia research stories of the year. And then finally, we also promote dementia-friendly research, which is the type of research that meaningfully engages with people affected by dementia and invites them to collaborate, participate, and advise on research projects.
Thank you so much for providing all that information. So if there's someone listening here that is really interested and wants to learn more about research, where can they go to learn more about dementia research? Where would you direct them?
Yeah, that's a great question. So if you'd like to learn more about research and the Alzheimer's Society of BC, you can check out the research section of our website. You can subscribe to our 2 quarterly newsletters, Insight, which is designed for people living with dementia, and Connections, which is designed for care partners, healthcare providers, and the general public. You can also check out the 2020 Focus on Research, which you can see on the screen and is available on our website. And you can always get in contact with me if you have a specific question, and you can see my contact details there at the bottom of the screen.
Perfect. Thank you so much. And then what about if someone wanted to actually participate in research themselves? What's the best way for them to get involved?
Yeah, that's a really great option. Researchers are always looking for participants, whether you are living with dementia, a care partner, or an otherwise healthy adult, there are always options to participate. And while the pandemic has changed the types of studies that are being done, there are still lots of opportunities to participate online or over the phone. And participating in research can be a great opportunity to provide hope for yourself and others who are affected by dementia, and a really great way just to stay engaged and active in the community. There are always potential risks and benefits to getting involved in research, but if you are interested, we really encourage you to check out the Participating in Research section on our website, the Alzheimer's Society Research Portal, or you can always visit the Reach BC platform, which matches people based on interest and eligibility with studies that are currently recruiting.
Wonderful. Thank you so much, Daisy. And I'll also just note that, of course, as Maria mentioned, you can always call us through our First Link Dementia Helpline for information or support. From Monday to Friday, you'll see the numbers listed here on screen, as well as the times each line operates. We offer support in English, Mandarin, and Cantonese, as well as Punjabi. So thank you so much for that information, Daisy. I will mention that links to all the different resources we mentioned will be sent to you by email after the presentation. So if you didn't quite catch something that we referenced, you'll be able to check it out and learn more. So now it's time to spin the wheel. I'll just adjust this here so we can see it a little bit better. Perfect. So each number on this wheel relates to a question that we've prepared on dementia and research. And we have updated the question since last time, so you won't necessarily have an advantage if you tuned in before. All fresh questions. And if you participate and answer a question here as a brave volunteer, we'll send you some society swag in the mail. So that's always fun to get a little surprise. So Christine, I think you maybe had some volunteers lined up for us.
I do. Thank you, Avery and Daisy. We have Donna up first. Donna, your mic is open.
Hi. Hi.
Hi,
Can you hear me?
Donna.
Hi. Great,
Yeah,
great
can hear you.
presentation. Very, very good presentation. Thank you for it.
Oh, wonderful. I'm glad you found it useful. I'll take a spin. Do you want me to spin it hard, softer? Do you have a preference?
Whatever way you want, just like life.
Here we go.
Okay, question number 8. So Daisy will read you out your question.
Okay, Donna, this is a true or false. Exposure to aluminum in cans, cookware, and antiperspirants has been proven to cause Alzheimer's disease.
Wow. I've heard so many controversial figures about this one. I would say false.
Yeah, you're right. It is a really controversial topic. And during the 1960s and 1970s, aluminum emerged as a possible suspect in Alzheimer's disease, and the suspicion led to concern about exposure through everyday sources. But since then, studies have failed to confirm any role for aluminum in causing Alzheimer's. And experts today focus on other areas of research, and very few believe that everyday sources of aluminum pose any threat. You got it right.
Daisy, the only reason I got it is because we have so much false news, and it went through my head and thought, oh yeah, I heard all that. I bet you it's not true.
Yeah, that's such a good point. It's so hard often to check what research we hear is reliable because there's so much news coming out, and research is often really complicated. And so, you know, when we read it in the news, it's kind of like a game of telephone by the time it gets to us. But you got it right. Good job.
Thank you, Daisy. Thanks.
Thank you.
The next up is Andrea. So Andrea, I'm just going to unmute you. Hi, Andrea.
Hello.
All
Okay.
right.
Okay, Andrea, I will give it a
Okay.
spin for you.
Great, thank you.
I did a lighter spin that time. Go and mix it up.
Okay.
11.
Okay, number 11. Andrea, let's see. This one is another true or false. True or false? There is nothing I can do to reduce my risk of getting dementia.
Oh, that is false. Definitely false. There is something you can do.
Yeah, you're right. That is false. There is no way to 100% prevent yourself from developing dementia, but there has been a lot of research showing recently that there's things you can do to reduce your risk. Specifically, there has been research that's found kind of 12 modifiable risk factors that contribute to about 40% of dementia cases worldwide, which is a really high number. And those include low education when you're younger, hearing loss, traumatic brain injury, high blood pressure, excessive alcohol consumption, obesity, smoking, depression, social isolation, physical inactivity, diabetes, and air pollution. And those are all throughout your life. So even making a difference in one of those, what we call modifiable risk factors, later in your life can actually make a really big impact on whether or not you might develop dementia.
Yeah, one of them is my job. I'm a rehab assistant. I give people exercise and Fraser Health.
Perfect. That's amazing.
That's wonderful. Thank you so much, Andrea.
Thank you.
Thank you, Avery and Daisy. That was great, and you know, those questions always get one thinking. So appreciate a little bit of that trivia. So we're going to get started and hear from our first researcher. Before I do, though, I'd like to pass on some regrets from Sutinder Kaba, who is the Director of Elder Care at Providence Healthcare. And she had really hoped to join us today to share some words, but unfortunately that just didn't line up. So again, I just wanted to express her regrets. But now I have the pleasure of introducing a very special individual, Dr. Lynn Beattie. And it could be really an hour spent talking about all the amazing things that Lynn has done throughout her career. And in the early 1980s, Lynn was the founding director, the founding head of the UBC Division of Geriatric Medicine, and went on also to become the director of CARD, which today is the Clinic for Alzheimer disease and related dementias. And CARD is still a very active place out at UBC, seeing over 3,500 people a year with dementia diagnosis and really supporting those families across the province. Lynn was a director at the clinic for many years on and off, and came back and helped them out when there were things that were changing, and finally retired there in 2013. But that really wasn't true retirement for Lynn. She went on to do many, many more things and really make a difference. She has a passion for neuroethics. She has certainly worked at looking at supporting First Nations and understanding the bridge between First Nations and traditional Western medicine. She has been the chair of the Alzheimer Society of Canada Research Policy Committee. She's also been the president of the Canadian Geriatric Society, the American Geriatric Society, and as well, she still is currently the director and chair of the Pacific Alzheimer Research Foundation. Most notably, in 2012, Lynn was awarded the Queen Elizabeth II Diamond Jubilee Medal for all her support to the Alzheimer Society of BC. But you know, I have to say, Lynn holds a really other special place for me. She is very much an accomplished professional, as to all those citations really speak to. But the thing that always has impressed me about Lynn is that despite everything that's going on, her true passion and commitment to helping people living with dementia, she is always laser focused on that vision. And I know many times over the past 7 years that I have worked at ASBC that I have called Lynn very frustrated about things just not moving in the way I'd like them to. And she was always so patient to listen, and then to always say to me, Maria, things do take time, but be patient, don't lose focus, keep moving ahead. And that was advice that I will always think of when I think of Lynn. So Lynn, we are so glad to have you here today and look forward to hearing your presentation.
Thank you very much, Maria. It's a little embarrassing as you go over that, but when I look at my title for this talk today is it's looking at life from both sides now. And you could guess that at one time I was a clinician and clinical researcher, and now I'm theoretically retired. And it's interesting as you go through a career like I did, a career in geriatric medicine, and it was very exciting because it was at the threshold of the evolution and development of the whole specialty of geriatric medicine in Canada and in other countries. And we also often talked about our geriatric patients, but you know, the reality is them are us. And that's where I am at the present time. I think I'm one of them, some days anyway. Joni Mitchell was a prominent folk singer when I was in my early stages of my career, and there's music that goes with this slide.
Tears and fears and feeling proud to say I love you right out loud. Dreams and schemes and circus crowds, I've looked at life that way. But now old friends are acting strange. They shake their heads, they say I've changed. Well, something's lost, but something's gained in living every day.
So the objectives of this a relatively brief presentation, because we have another presenter who's going to get into the nuts and bolts of exactly what we do about all of this. But the first thing I want to talk about is to identify the risk factors for dementia, which includes Alzheimer's disease and related disorders. And Daisy was wonderful in her presentation of the items. So this is going to be a bit of review. So it's repetition for understanding for all of us. And then I want to talk about how we understand what the usefulness of knowing about these risk factors is, and how we can turn some of these risk factors into prevention. So we want to understand prevention broadly. And then I just want to take a little bit of time to review a couple of factors which could review risks, which could modify risks. And the two that I'm going to emphasize really are frailty and social contact. So as Daisy said, we have been working on trying to understand what the real risk factors for dementia, particularly Alzheimer's disease in Canada, and the Canadian Study of Health and Aging looked at that area. And one of the first situations that they talked about as a risk factor, I should say that we talked about because I was very involved with this study. And if you have one or more first-degree relatives with dementia, the likelihood of you getting a dementia yourself is higher. Now, this is not a risk factor that you can do something about because we're born with the genetics that we have, but that is still a reality, and then you notice that that won't be included in the current risk factors. Fewer years of education is certainly one that's included in the current ones, and the items that I've underlined here are the ones that are also occurring in the later enumeration of risk factors. In the Canadian Study of Health and Aging, they put coexisting conditions which included peptic ulcer, migraine, but also depression and head injury or traumatic brain injury. And we'll see that appearing again. And we've already talked about antiperspirants, and at the time that we did the Canadian Study of Health and Aging, the total resolution of the roles of aluminum and so on hadn't been put down in a good way. Another item that came up was drinking tea, and there was a lot of discussion about that, but it's interesting that it hasn't come up in any studies since then. But there have been two other factors, smoking and alcohol, which were included in the CSHA risk factor enumeration, and they're now in the current risk factor enumeration, which you'll see. And the other thing in the risk factor list from the CSHA was at least a difficult recovery from anesthetic, if not the anesthetic itself. And to me, that's one thing that needs some more work, and it hasn't been included. So the dementia risk factors first published in 2017 are the ones, these 9 that Daisy enumerated. And I really want to underline the low social contact, because social contact is such a big issue for people as we all get older. And it's such an important thing that is being restricted for all of us now, because we can't do all the social issues that we used to be able to do. And we need to make special efforts to work on that. And hearing impairment is in this list. And I can't tell you how many patients that I've seen when I was in clinical practice who had hearing aids, but they were in the drawer at home. And I said, this is both sides now, and my daughter says that I have impaired hearing, and I've been trying some hearing aids, and it's less satisfactory than it should be. It's a lot easier to wear glasses to see better than to wear a hearing aid to hear better. And we need to work further on that. And I remember years ago, I recommended a hearing aid for an 85-year-old patient, but she was saving her money for her old age. And I tried to suggest to her that the time has come. And she argued with me and refused to do anything about it. And it is true that seniors, when they can, are often reluctant to spend money for their own devices. And even the opportunity to attend an adult day center, which sometimes seniors have to pay extra money for, is something they don't want to spend money on. And the longest I've ever taken to convince a patient to go to an adult day center was 6 years. And the spouse said to me, I don't know why she didn't go there before, because she just enjoys that so much. I didn't know why either. But we have in 2020 3 additional risk factors: the excessive alcohol consumption, traumatic brain injury, and air pollution. And we have just, well, we've got mist today, but we've just had the worst weather in the world through Vancouver, the lower mainland, I believe. And air pollution has been a big factor with these nanoparticles that aren't obstructed by regular masks, and so we've all had to spend a lot of time indoors. So overall, I think these 12 risk factors altogether are the foci that we should look at for prevention. In other words, if we understand what are the risky factors, we can discover prevention. Now, there are 3 kinds of prevention. There's primary prevention, which is an intervention so that the illness or disability doesn't occur. And we have legislation for seat belts, helmets, and now social distancing is part of everybody's vocabulary. Theoretically, that could be related to primary prevention. And immunization has been long thought as a very specific item for primary prevention. And we know that the use of smallpox vaccination or polio vaccination has made a huge difference around the world. One thing about prevention, though, if it's successful, then we don't see a problem and people kind of forget about it or byplay it and so on. And I think that it's very important for us to be considering continuing immunization. And for example, everyone needs to get a flu shot shortly. But it's also touted that this could be the end of our pandemic if immunization were available. And that really remains to be seen, because we also have secondary prevention. And secondary prevention means that we detect a potential problem early and try and do something about it. For example, we know that individuals who have high blood pressure or hypertension and have treatment for that are less likely to get a stroke. But I'm also got immunization in the secondary prevention category, because, for example, there's a lot of information that influenza immunization doesn't necessarily 100% prevent you from getting influenza or the flu when it's coming around, but there is a lot of data that shows that people who have had influenza immunization are less likely to be hospitalized or die. And so there is some value in it. And finally, there's tertiary prevention, such as how can we soften the impact of a disease such as dementia or frailty, particularly in residential long-term care. And to me, one of the critical things that we need to have for an intervention is adequate numbers of adequately trained and adequately paid personnel in residential long-term care. And this is something that I have been advocating for a long time, and it's very hard to move the needle in terms of making more of these things happen. And I'm hoping that this pandemic will really be increasing the activity and sympathy for really doing something about the situation in long-term care, residential long-term care particularly, but also in community long-term care. And training and numbers of people who are adequately paid is really crucial. Now, one thing is that things change as all of us get older. And if you look at younger people, more younger people are cognitively normal. More older people may be cognitively impaired, and age is the biggest risk factor for getting dementia. It's also the biggest risk factor for being frail. And an autopsy study was done of a group of people over 90 years of age, and there were over 1,000 people in the study. And when they looked at the brains under the microscope, Alzheimer's disease in the neuropathological samples accounted for about half the cognitive decline. But Alzheimer's disease changes were not on their own in these people, and they had a number of other changes in their brains which could contribute to their dementia. And only 9% had pure Alzheimer's disease pathology. But in addition to this, they also looked at pre-death measures of frailty of these individuals. And they noticed that as people were more frail, the odds of them having Alzheimer's disease neuropathology decreased, but they could still have a dementia due to a number of other factors. So one of the things that we can do when we understand that frailty is a risk, particularly for people who are in residential long-term care and have a dementia, if we modify the situations that are contributing to their frailty and then thereby decrease the severity of the impact, or at least provide a tertiary prevention by decreasing the impact of the dementia itself. Frailty is a state of increased vulnerability resulting from age-associated decline in reserve and function. It's not necessarily synonymous with disability or comorbidity, but it is measurable. And we do know that physical activity and exercise, and we heard one of our persons who answered the questionnaires from the Alzheimer's Society is doing just that, I believe. And there is a relationship between frailty and changes in cognition. And there's a complex interaction of physical and mental health, changes in function, and social context. And we need to have directions, both clinical and policy directions, to help these people. Interventions targeting even one thing, for example, frailty or social vulnerability, may bring benefits for other factors, including the impact of dementia. And this, in fact, is one of the major themes of the Canadian Consortium on Neurodegeneration and Aging, which is a national research undertaking. And they're looking at just what could be changed here. And again, I'm coming back to COVID-19 and its huge impact across the country and in North America on residential long-term care, affecting older persons. And we know particularly there are frail older persons with dementia in residential care. There are preventive situations which were all, there's talk about pandemic fatigue. People are tired of learning or hearing about personal protective equipment, including masks, social distancing, hand washing, stay at home if you're sick, particularly if you're a family member or a staff member. And we can't lose sight of this. It's extremely important for us as we go forward, because they are issues. This disease can change the courses of so many people. And in residential long-term care in British Columbia, early in the pandemic, COVID-19 revealed the magnified significant systemic issues, and prompt attention was focused on care staff, including payment and preventing persons from working in more than one location. And ongoing review of the funding of residential long-term care and review for profit and not-for-profit operations with a look at responsibilities and accountability is very, very important. It's ongoing, and with any luck, we'll see some changes. There was a situation in Ontario that was reported in the Canadian Association of Retired Persons magazine, but we had heard about it in the news, and there was potential prevention of nursing home murders in Ontario because over 7 years a nurse gave insulin overdoses to at least 12 residents and 8 died. The question was, who failed to protect these vulnerable older people? And so a public inquiry was set up to help. And the question is, would it make a change? Would it prevent abuse and neglect? And the person was Elizabeth Wetlaufer, which has been publicized. And in 2017, Eileen Gillese oversaw a public inquiry to investigate the events. There were 2 years accumulation of damning evidence, and she outlined 91 recommendations to address systemic failures. This was particularly focused for Ontario. It included stronger education and training, infrastructure changes, increase in numbers of registered staff, and addressing low staff pay. Just the issues that are extremely important. And unfortunately, the evidence that many of these recommendations were carried out was not present because there were so many problems in residential care. The other area that is really important, we noticed that limited social contact makes dementia worse. That makes dementia riskier. And family caregiver opportunities are so important. There's such an interdependence, and particularly again when we come to residential long-term care, but also it's similarly important in the community. And the dementia journey may offer avenues for reconciliation, healing, and joy. It's not all negative. Significantly missing from residential long-term care with COVID-19, this important social contact has been so limited and is even more profound when residents are dying. In other words, FaceTime is helpful, but it is not a hug. And when we think of all our relatives and friends who are in this situation, it is extremely difficult to manage on a day-to-day and cope with all of this I'm glad we have social media and opportunities such as FaceTime or iPads, but it's just not quite the same as a personal interaction. So this is something that we really need to be aware of, because not having social interaction can make a bad situation worse. That is, a person with dementia not having an opportunity to have personalized interactions with their family is very, very difficult. So in residential long-term care, and I think part of this applies to the community as well, but there's no substitute for adequate numbers of adequately trained and adequately paid staff in residential long-term care. And COVID-19 risk has affected family interactions significantly, and the critical social tertiary prevention has been so limited. So we have 12 modifiable risk factors for dementia, which have been identified. Dementia with loss of cognition, function, and interaction of frailty leads to increasing vulnerability. And prevention, clinical and policy strategies can be in place to mitigate the negative impact of dementia, even in the face of a scourge such as COVID-19. But it's very, very difficult in this situation.
I've looked at life from both sides now, from up and down, and still somehow it's life's illusions I recall. I really don't know life at all.
Thank you. I just love Joni Mitchell, and at the beginning of my career, which was in Toronto, she was in the coffee houses in Yorkville, but I didn't hear her in person, and love to listen to her now. Thank you very much.
Thank you, Lynn. That was just a wonderful presentation, and yeah, I could just start singing the whole entire song of Joni Mitchell. So thank you for that. I think we're going to do some questions now, and Christine, I believe you're going to facilitate that, and just reminding people that if you have questions, to please raise your little hand, the little icon on your screen. I was going to say it's on the left of your screen, but it's on my right of the screen, so I don't want to mislead people, but the little hand icon to click on if you have a question, or you're welcome to tap or type the question in the chat box, and Christine will read those out and direct them to Lynn. Thank you.
All right, the first question is Donna.
Thank you very much, Lynn, for the presentation. Everybody throws around the word Alzheimer's and dementia, and they interchange them all the time. Can you differentiate it for me, please?
Dementia is the umbrella term, and Alzheimer's disease is probably the most common cause of dementia. What I was trying to point out is that the older the people are, and in the cohort that was studied by autopsies, relatively few people had pure dementia, but they probably had some Alzheimer plaques and tangles in their brains, but they also had a variety of other things like small strokes, or they could have had Lewy body disease and so on. But dementia is the umbrella term, and there are several types of dementia, and the older people are, the more likely they are to have what we call a mixed dementia.
Can I ask a further question? When my husband was diagnosed, the neurologist said there were plaques in the brain, but he said that doesn't necessarily mean that it will be Alzheimer's or dementia. It turned out it was, definitely it was. So how can you differentiate plaques in the protein as not Alzheimer's? Because I lived with the hope that it wasn't, and it turned out it was. So I was given false information. Does that often happen?
Well, perhaps on that note, we'll get going again. And thanks to, it sounds like perhaps Mother Nature, Lynn was disconnected for a period of time, but we have her back. So we have a few minutes. So what we thought we would do is, Lynn, maybe you could just finish that thought that you were sharing with us when the connection went down. And then there were a couple questions in the chat box that Christine will pass along to you, and then we will move on with Dr. Henri-Bhargava. So Lynn, over to you again.
Well, thank you very much. I was just speaking about the difficulties with diagnoses, and overall, when a person has dementia and has impaired function related to that dementia, in terms of specific causes, it doesn't necessarily really matter which of the plaques or tangles or Lewy bodies or whatever is in the brain. The reality is the person needs care, which in order to complement their function. And now, though, there are biomarkers to measure plaque and tangle materials like tau and amyloid, etc. So perhaps the diagnoses can be clearer. At the same time, it's going to be still a challenge about mixed dementia, but we saw Robin Schung, and that's one of his interests in his research program, looking at mixed dementias and seeing how that can be sorted out more effectively clinically. So could we have the next question?
Yes, the next question comes from the chat. And it says, they say that the last memories we have are musical in nature. Is that a help for the elderly?
Well, I think it's a help for me and for many people. And I know that I have interacted with patients and families, and some people have found that there are certain types of music. Some people really like classical music, and they found that if they have classical music or podcasts with various kinds of music on them, that their agitation can be decreased for individuals. And we know about the choir that the dementia people are participating in. And I remember years ago, there was one lady living in Purdy Pavilion who was not speaking at all. And then they put some Glenn Miller music on and she sang along, and everyone was very surprised to hear about that. So I think there's as many individual interactions as there is spectrum of kinds of music, and finding the one that would be comforting or helpful for people is sometimes challenging, and sometimes it's just by knowing who they are, you can figure it out.
We have Lara is asking, can you please speak on prevention of Alzheimer and dementia?
Well, thank you for that question. Well, what I tried to do was enumerate the 12 risk factors, which have been shown in various research projects to be risk factors as far as developing Alzheimer and related dementia is concerned. And I think our next speaker will be focusing on some particular aspects. I just talked a bit about how important social context is, and how important recognizing frailty and seeing what can be done about that is. But there are many other options, and we've already mentioned physical activity, and you can stop smoking and not drink too much alcohol. But I'm going to leave that for Alex.
Thank you, Lynn. How much value would you put on cognitive stimulation activities? And that's from Andrea.
I put a lot of value on that, and cognitive stimulation activities can just be conversations with people. And that's why some of the electronic devices that we have and the interactions can be extremely helpful. And I go for walks in my neighborhood, and I've got a lot of new friends because I talk to everybody as I go. And I come home and I feel a lot better and feel more energetic and more interested in things that are going on. So it doesn't have to be complicated. I don't think question and answer kind of things are necessary, making sure people know what day it is today.
Well, that's a perfect way to end a very informative presentation. Thank you, Lynn, and glad we were able to get you back so that we could have some questions and answers. Now I'd like to move on to our second speaker, Dr. Alex Henri-Bhargava. And Alex is a neurologist. He has a fellowship training in behavioral neurology, as well as a master's in healthcare teachers education. He, very much like Dr. Beattie, wears many hats. He's a clinical associate professor at UBC in neurology. He runs an outpatient clinic in Victoria, supporting people with cognitive deficits and disorders. He also supervises clinical trials looking at assessment and treatment for people with cognitive disorders. He is also the medical director for a very interesting initiative called the Neil and Susan Manning Cognitive Health Initiative on Vancouver Island. It's a partnership between the University of Victoria, Island Health, and UBC, and it's donor funded to look at a number of very specialized health initiatives. Alex also is responsible for the training and the coordinating of medical students in Victoria. But beyond all that, I also have a very special connection to Alex. Often the Alzheimer's Society of BC goes off to Parliament, the provincial government, and spends time with a variety of the different parties to help them understand the issues that people are facing when they are trying to get health care and the appropriate support through the healthcare system. We also are trying to help the elected officials understand what the healthcare practitioners are experiencing while they're trying to provide care. And Alex has always been willing to come along and speak to a number of politicians, express his views, translating very complicated healthcare conversations and systems into very plain language, and it's really made a big difference. So it's great to have you here today, Alex, and we look forward to hearing from you.
Well, thanks very much, Maria, for that really overly generous introduction, and thank you to everyone who's taken the time to join us this afternoon. You know, usually this would take place as part of the Dialogue on Aging event that bookends the Geriatric Services Conference, and you know, kudos to the organizers for pivoting into a format that could work during the pandemic. So I appreciate everyone's time here. I would say that I wasn't told that I was going to be following the indomitable Lynn Beattie when I was asked to present, and so you know, it's a tough act to follow for sure, and I always learn a lot when I listen to Lynn. I'm actually going to touch off on a few themes that Lynn spoke about already, but looking at the questions that were coming in at the end, I hope that what we're going to cover today resonates with the people listening. It certainly will answer some of those questions that came in. So I'm going to see if I can get these slides to work. There we go. So hopefully what you're seeing is mine. So I do have these disclosures in that some of the small research work that I do is industry sponsored by nature, because we participate in clinical trials. I'm also involved in a little bit of non-industry sponsored research, but I'm not going to really be discussing any products or services related to these interests in this talk. So, and in fact, today, I don't think I've mentioned a single medication, so I don't think there's any conflicts of interest that are going to really come through the talk. But you know, just hear that what I have to say is from the perspective of a physician who diagnoses and treats patients who have suspected or confirmed cognitive issues, and so you're obviously going to be getting a medical perspective on this issue here. What I'm going to do is just very briefly touch on what are some of the changes that occur in the aging brain. give a brief overview of dementia to make sure that we understand what we're talking about when we're talking about dementia versus aging, introduce the concept of brain maintenance, and again, I think this is going to be expanding on what Dr. Beattie introduced us a little bit, and try to go through some very practical lessons for brain maintenance, and then how we can apply those lessons during the current pandemic. So the aging brain, what happens to your brain as you age? So there are a number of changes that actually happen as part of normal aging, just like the visible part of your body that you can see changes with age, and you get a few extra wrinkles and maybe a few extra belt sizes and lose some hairs, and that happens to varying degrees to everyone. Same thing internally in the brain, there are some changes that happen to varying degrees in all of us. So there will be some shrinking of the brain, or what we term medically atrophy, that happens. This is not uniform in terms of how much it's apparent across all regions of the brain, and it happens due to changes in the brain cell shapes and connections, as well as the death of some of our brain cells themselves. And then there's changes in brain networks, so the connections that are made in the brain and how those connections function change over time as we age. So this is an example of a particular network in the brain that has been the subject of a lot of research in the last 20 years or so, called the default mode network, which is if you put a patient doing a psychological experiment in a functional scanner to try to understand what parts of their brain lights up when they do such and such a task. So what part of the brain lights up when they're talking or eating or whatever it is. The default mode network is actually the part of the brain that lights up when they're not doing anything. So it's the part of your brain, it's the network in your brain that's kind of ready and primed for you to jump and do something. And we can see that there are changes in the connectivity in that default mode network as we age. And so this is coming out of a lab in Iowa that's done some research on this. I'm not going to go into all the details. Here's some Canadian work in the same field. Cheryl Grady in Toronto did this work 15 years ago, where she and students in her labs showed that if you give participants tasks to do where they switch from the mode where their default mode network is engaged to some other network in their brain and back, the efficiency of engaging that default mode network changes over time. And so these are areas in the brain that as the default mode network engages, you see an increase in switch off, and areas in the brain where you see a decrease in switch off. So basically, what your brain looks like changes, and then we're at the point now where if we give people things to do in some functional scanners, what we can see in those functional scanners changes as well. And so the result of those changes is that our cognitive functions, so our ability to do things with our mind, also changes. And so certain functions, unfortunately, decrease as we age. Our focused attention, aspects of memory, so what we call working memory, how much information you can keep in your mind at the same time, and then also aspects of episodic memory, so remembering events and things like that, which is why many seniors speak about having seniors moments. And some aspects of complex problem solving, as can be measured in psychological tests, decrease over time. Certain functions continue to improve and seem to be resistant to these changes. So in fact, empathy and certain social skills, again, as measured by psychological experiments, and vocabulary, for example, if you don't have a problem with aging, such as dementia, then vocabulary should continue to increase as you age. And so this is just summarizing many studies that have been done looking at this, and these are aspects of working memory, other aspects of memory, and then speed of processing is something I didn't mention on the previous slide, that decrease with age, whereas world knowledge, as measured by vocabulary, increases with age. And here is, if you look at how this can be measured by tasks of analytical reasoning, you see that over time, patients at different age groups had decreased performance on the analytical reasoning task, but they did better on the New York Times crossword puzzle, which is a measure of their vocabulary. That being said, much like the changes I talked about earlier, the wrinkles, the loss of hair, whatever it would be, the external changes of aging, these changes that happen in your cognitive functions, there's a lot of variability. And so we actually see that there are some people who have, the changes that we expect to see. Some people decline more rapidly than the average, and then there's a proportion of people who seem to maintain most of their cognitive function despite age. And so there's research being done in super agers who don't get much worse with age. And so for those of you who don't know, this is Professor Brenda Milner, who celebrated her 102nd birthday this year at McGill University, where she still teaches. And she was a big reason why I got into this field, was listening to her lectures as a medical student. And she still supervises students and goes into the university every day. So she would clearly be in this category of super ages. On the other hand, we have people who are on that downward slope that I showed you, and then possibly dementia. And this is a contentious issue in that, does dementia really represent one of the extreme poles of aging, or is it really something separate than what happens in the aging process? And that would fill a whole talk just talking about what we think about that. But if I think of the perspective of somebody who might be in the audience today, I think common questions that people encounter as they age is, well, if I'm starting to have seniors moments or forgetfulness or some event, where am I along that spectrum of aging? And am I aging normally, or am I developing dementia? And even if I don't think I'm developing dementia, what can I do now to reduce the risk of developing dementia down the line? And of course, this question was already asked at the end of the last presentation. So I'll just give a very brief overview of what we talk about when we're talking about dementia, just so that we're all on the same page in terms of vocabulary. So the word dementia doesn't refer to a specific disease. It refers to kind of a syndrome or it's a description of what's happening to a person. And in the psychiatry textbooks now, the word dementia has been taken out, and it's now called major neurocognitive disorder. So if you're told by a clinician that you have major neurocognitive disorder, that would be synonymous with what we used to call dementia. So again, it's a descriptive label. It's not a specific disease. And one way to think of it is that there is an abnormal or accelerated, again, some debate, change in your brain structure and function that manifests as changes in your cognitive ability and a loss of day-to-day function. So not just a little slip up here and there, but something that's significant enough to impact your ability to function as you previously would. And it's associated with some presumed pathological change in the brain. So for example, the pathological changes of Alzheimer's disease or cerebrovascular disease, such as silent or even overt strokes. And then there's other pathologies associated with that. And I'm going to expand on that for a second, because it answers one of the questions that was asked earlier, is that sometimes we have a pretty good idea that we do have these associated pathological changes. In the cases of strokes, for example, we can do an MRI scan and we can say, oh gosh, this patient has had all these strokes that we see on the MRI, and the pattern of strokes really clearly explains the type of dementia they have, and therefore I'm very confident that this patient has a vascular dementia. But in some cases, we don't see the changes because the changes are microscopic. So the changes of Alzheimer's disease, by and large, outside of research settings, we cannot see those on scans that we have available in day-to-day clinical practice. And so we take the patient's symptoms and we say, well, I suspect that you have plaques and tangles of Alzheimer's disease, but I would only really know that if I took your brain and was able to see it under a microscope, okay? And so the most common pathological changes that are associated with dementia are Alzheimer's disease, Parkinson's disease, and related disorders such as dementia with Lewy bodies, forms of frontotemporal degeneration, which includes frontotemporal dementia and primary progressive aphasia, vascular dementia, and then probably the most common is actually a mix of more than one of these two. And so there's some thought out there that degeneration begets degeneration. Many patients who are diagnosed with vascular dementia also have some of the plaques and tangles of Alzheimer's disease and vice versa, and there's also overlap between some of these other conditions. And so when we're talking about plaques and tangles, we're actually talking about something way back to 1906 when Dr. Alzheimer wrote his paper. He said, well, this is what a normal brain looked like. And then the autopsy of his patient, who he had described having this peculiar syndrome where she was losing her memory, he saw that the brain cells had this junk accumulated in it, which he called neurofibrillary tangles, and then had these deposits of amyloid plaques around it that were not normal. And now we know that the amyloid is a protein called beta amyloid, and the plaques are a protein called tau. So coming back to the question of superagers or even normal agers who don't develop dementia, that's a real question that is, you know, the Nobel Prize would go to somebody who can decipher this with certainty. Why doesn't everyone develop dementia? How come this gentleman at the age of 105 is still competitive running, whereas someone at the age of 65 may be unfortunate enough to develop dementia? And we only have partial answers to that, but there is a concept of what we call brain reserve. And so that is what you've got. So if you go for a race in a Ferrari versus a race in a Lada, it doesn't matter what kind of shape your Lada is. When you start off with the Ferrari, you are just given a much better chance to win the race. And so the brain reserve refers to factors that you didn't really have any control over, that you were born with, that may contribute to why you're less likely to develop dementia. On the other hand, cognitive reserve, which Professor Albert has described as individual differences in lifetime experience that modify the relationship between the brain pathology and cognitive performance, that's what you do to your brain over time to keep it in shape. So you could have two different cars, but if you don't take care of this one, this is what it'll end up looking like. And if you are immaculate with the care of your car, this is what you have at the end of 30 years. So brain reserve, roughly speaking, what you're born with. So things like the size of your brain, the number of neurons and neural connections. And both of these are probably influenced by genes, but there are other genes that influence brain reserve in other ways. And there are many factors that play into brain reserve that we don't yet understand. And cognitive reserve is what you do with it. And again, there's some factors that have come out as being known now to contribute to cognitive reserve. So what kind of education you have, what your vocational history is, what kind of hobbies and interests you partake in throughout the lifespan that will contribute to resiliency of your brain over time. Some interesting work has been done here in Canada looking at a contributor to cognitive reserve, in that bilingualism seems to be a factor that contributes to cognitive reserve. So in this study, they showed that people who were bilingual on average had a 5-year delay in their diagnosis of dementia compared to people who are monolingual. And that has since been reproduced in other settings. This was reproduced in Tunisia, I know for sure, in I believe it was parts of Russia, and this has been reproduced in other countries in the world. This finding is a fairly robust finding. So just speaking 2 languages throughout your life seems to give enough challenge to your brain to maintain it so that it may delay dementia. Music, in terms of how it is processed, has many factors that make you think of a language, and it does look like musical ability also is a factor that will help with cognitive reserve over time. And so here they were able to show that on various neuropsychological performances, seniors who were high activity musicians perform better than non-musicians, and these are obviously non-musical tasks. So those are some of the factors that lead to the cognitive reserve. And so if we go back to this study that I showed you, where they followed some people over time, and they realized that people were separating out into these groups, where you had an average group that showed the average change in cognition over the lifespan, and then there was a group that seemed to maintain their cognitive function much better, whereas another group was declining a little bit more rapidly. They found that about 1/5 of people were in this maintainer, and about 13% were in these rapid decliners. And then they were able to go in and look and see whether there were factors that could be teased out this to say being a maintainer or being a decliner. One of them was actually sex, and for once, women have an advantage or given an advantage in the study in that female sex was a predictive of being a maintainer, whereas male sex was predictive of being a decliner. And then there was these gene variants that were found to be predictive of being in the group, but some of the factors that were identified were actually potentially modifiable risk factors. So whether you were higher education, living with someone, or had good levels of physical activity was predictive of being in the maintainer group, whereas if you were of lower education, this was predictive of being in the decliner group. And there's other factors that have been found in many other studies in the 8 years since this one was published. So this brings the concept of brain maintenance as an emerging concept, right? If you can't do much about what you're born with, but the factors that seem to be influenced over the lifespan, you may be able to take charge of those factors to maintain your brain as much as possible and reduce the risk of developing dementia down the line. And so, you know, rather than waiting until you have dementia to worry about it, maybe we should all be looking in midlife but even as we enter our retirement years in ways of postponing senescent brain changes. And you can't go to a talk on this topic without seeing this slide. This is from the Lancet Commission report on the preventable risk factors for dementia. And this is the second version of this report. It was initially published in 2017 and was republished earlier this year. And these are the 12 factors that Dr. Beattie was talking about in her talk that have been shown to be contributors of developing the risk of dementia. And so this large analysis of hundreds and hundreds of other studies, the bottom line is that perhaps up to 40% of the risk of developing dementia is potentially modifiable. And so if we could make a dent in some of this risk, we could actually reduce the prevalence of dementia in the population. I do want to say that it's important to state that so far it looks like 60% of the risk may not be modifiable. And so if someone's unfortunate enough to develop dementia at any point in their life, you shouldn't necessarily view this as that they made poor lifestyle choices and that's why they have dementia. You know, there's a lot of shaming that happens around medical diseases in popular culture, and we say, well, you know, people who have diabetes should have just eaten better, and people who suffer from obesity should eat better, and so on. But the truth is often more complex than that, and certainly, you know, as individuals, we should all focus on what can we do with this modifiable 40%, but not forget that some of it is just not modifiable at this point. But focusing on the 40%, what are the lessons that we've learned for brain maintenance? And so when I'm sitting with a patient during an appointment and they ask me, what can I do right now if I don't have dementia or if I'm worried about developing dementia to try to reduce the risk of developing dementia? And so, again, Dr. Beattie mentioned this, but I think this can't be repeated often enough. It's surprising that of all the risk factors highlighted in the Lancet Commission report, the biggest one numerically is hearing loss. And so there is definitely a relationship between hearing loss and dementia, and midlife hearing loss may constitute 8% of the total risk. Now, there's a lot of research that needs to be done still to find out if this is a cause or a symptom. And some of the smartest people looking at this think that it's probably a bit of both. So the hearing loss may, in some instances, and we don't know how many yet, actually be a marker of brain injury. So, you know, hearing is a cognitive function, just the way remembering a list of words or being able to draw a clock is. We just don't always think of it that way. We kind of separate it as one of the senses versus you know, some of the psychological functions. And so if you're starting to have trouble with some things like being able to recite a list of numbers and words and things like that, then it may be that the hearing loss is another symptom of that. But the hearing loss itself leads to social isolation. It makes everyday tasks more difficult, and so there's certainly a vicious cycle that can set in place if there is hearing loss. And so I think it is very important for people to address hearing loss if they have a concern about developing dementia. And I think this is particularly important during the pandemic, and I don't know why I put pandemics here, that we shift from to online and telephone lives, where you know, it's a little bit harder to hear in the first place. And so if you have some hearing loss, you may be excluded from the Zoom call with the grandkids or the telephone call to your neighbor that you would normally be able to see. Second lesson I'd like to make is that a healthy mind in a healthy body, this old adage seems to be true, and people are always interested in lifestyle and how that can impact on their risk of dementia when they have talks with me. The question is whether any specific supplements or vitamins or minerals might be helpful, and there's certainly some factors where we think that there are real reasons why these might help to protect the brain against neurodegeneration, but unfortunately so far none of them have been shown to actually yet be effective. So I can't point you to a clinical trial of omega-3 fatty acids showing that they do independently reduce your risk of developing Alzheimer's disease down the line. But if you want to look at what's been looked at, these are some of the factors here. There is a study with vitamin E in veterans who were also taking medication for Alzheimer's disease that did show some efficacy of that. So maybe vitamin E might be one of them. And at this conference, which is now 7 years old, and I don't think they've done a second version of it yet, or at least not one that I've seen, where they brought international experts in nutrition who were researching nutrition in the brain to come up with some common sense recommendations. The recommendations really did not focus on individual supplements. What they said is minimize your intake of saturated fats. Vegetables, legumes, fruits, and whole grains should replace meats and dairy products. So this is a lot of what we think of as a generally healthy diet and the Mediterranean diet that has been really touted. Vitamin E should come from foods rather than supplements. A reliable source of vitamin B12 should be part of your diet, and your vitamin B12 level should be checked regularly, because this is one of the supplements where if you are deficient in vitamin B12, then a supplement with vitamin B12 can make a real difference. If you have normal levels, the supplement is not going to do anything. Vitamin B12 is water soluble, so you'll just put it out in your urine. If you do use multivitamins, choose those without iron and copper, and consume iron supplements only when directed by your physician. This is this doesn't come up very strongly in many other recommendations, but there is a thought that excessive iron accumulation can be detrimental to your brain health, and then iron may compete with other nutrients for absorption, and so that's where things are. And this was already talked about, aluminum. I think we've pretty clearly proven that aluminum is not the cause of Alzheimer's disease, but this has been kept behind for people who say, well, until we can prove it for 100% sure, we should leave it as a recommendation. And that being said, it's very hard to prove anything with 100% certainty in terms of epidemiological relationships. And then, even though this was a consensus statement on nutrition, they added include aerobic exercise in your routine, recognizing that exercise was really complementary to diet. When they did a meta-analysis of 65 studies of people who already were diagnosed with mild cognitive impairment. So mild cognitive impairment means that there is a measurable change in your cognitive function that exceeds what we think of as the average curve for your age, and yet you have not yet developed dementia because the impairment is not severe enough to impact your day-to-day functioning. And so many people think that mild cognitive impairment in some individuals is a precursor stage to moving on to dementia. If you had mild cognitive impairment and you suffered from diabetes or prediabetes, your risk of progression to dementia increased. But on the other hand, if you were able to change your diet and follow the Mediterranean diet, the risk of progression to dementia decreased. So they were able to show that intervening on the diet can reduce the risk of progression to dementia. And as I mentioned, in the most recent Lancet Commission, excessive alcohol intake has for the first time shown up as a risk factor for dementia. And so there is this Canada Brain Health Food Guide, which is available free of charge on the internet, and I think is a good resource for people who want practical tips in how to incorporate dietary changes that might help prevent against the development of dementia. And so the Brain Food Guide goes over certain foods that may be very helpful. And I would add that this Brain Health Food Guide is also a heart healthy food guide, and it's probably it's really an adaptation of the Canada Health Guide with some specific recommendations for things that have been particularly researched as being good for brain maintenance. And so the easiest way to find it is really just to go to your Google search bar and type in Canadian Brain Health Food Guide. It should be the first link that shows up. You don't need to log in or anything. You can just download it for free and print it up or look at it on your computer. So moving on from diet to exercise, which was mentioned previously as well. So I showed you this this picture here of the changes that were seen in the default mode network connectivity between young and old subjects. But the same group that was studying this was able to show that with daily aerobic exercise, with 12 months of activity, the connectivity was restored to the levels that they were seeing in inactive young adults. And so are these changes really the effects of aging, or are they the effects of our changes in activity over age? And that's an interesting thing to research for sure. And so the recommendations at this point are that aerobic exercise and resistive exercise both have independent positive contributors, and there's different studies I could show you for each of them. And so the recommendation would probably be to combine both of those, and even moderate activity is good. And so it doesn't mean that you have to join a cross-country club and go running every day for an hour to get the benefits of exercise. This is just showing you numerous studies and a meta-analysis of all of these studies that showed that yes, exercise reduces the risk of progression to Alzheimer's disease, or to dementia at least. I added these slides at the 11th hour because I went to a very interesting talk on Monday, or I saw a very interesting talk by Zoom by Ken Madden, who's a geriatrician at UBC who does research in exercise in the older age group. And one of the things Dr. Madden's found in his research is that sedentary behavior and exercise may actually be two sides of a coin that to a certain degree are separable. And he made this discovery when he did a study that got a lot of press in the Whistler Seniors Ski Club, which, as you can imagine, is a group of very active individuals who are not typical of the average senior citizen. These are people who are out, in the wintertime skiing, downhill skiing quite frequently, and in the summertime cycling, etc. But when they studied the amount of sedentary behavior, which means butt time, for lack of a better word, time that you spend not doing anything, the folks in the ski club were no better than the average person. And so it may be that reducing sedentary behavior is another target in addition to just saying get out and exercise. And the appeal of thinking about reducing sedentary behavior is that it's easier to convince people to reduce their sedentary behavior than it is to really sign someone up who doesn't exercise into daily exercise routine. I think both are good goals, but we shouldn't forget the simple tasks of reducing sedentary behavior. So in this pilot study that he did with graduate students in his lab, he looked at this whole plan that he had for changing sedentary behavior, and one of them included this movement makeover, which was to think about, well, what do I do in a typical day that involves sedentary behavior, and how could I change so that I accomplish the same task and yet reduce the amount of sedentary time I have? And so one example here was, well, instead of driving all the way to work, I'll walk 10 minutes to the location to meet the carpool, or I'll park 10 minutes away. At lunch, make sure you use the lunch hour to go for a walk around the block. During work, take the stairs at the office, use the standing desk, set a timer to get up every 30 to 40 minutes. And some of the work that he and his colleagues have been doing has really focused on this. Just getting a little bit of activity every 30 minutes seems to really have some beneficial effects. So these are things I think if we sit down and look at our day and say, gee, I do spend 2 hours in meetings, maybe I should make sure that I get up frequently for a little 30-minute break in between that to break it up. That would be a good way of reducing sedentary behavior. Not enough focus is put on the relationship between mental health and the risk of dementia. And there's numerous studies that have shown that people suffering from anxiety and depression in midlife and in late life have a greater risk of cognitive decline. And again, here, there's sometimes a cause and effect question, in that perhaps sometimes the development of depression and anxiety may be the early signs of progressing or of a dementia that's evolving. So whether treating the anxiety and the depression really changes your risk of dementia isn't completely known, but I would argue that that's not really all that important, because it would be important to help people take charge of their mental health regardless. And so if you know that on top of that there's a link with dementia, it may add a little bit more convincing to help you to take the mental health seriously. This study is really interesting, again, 5 or 6 years old now, but where they looked at just the association of developing dementia with cynical distrust. So there was a questionnaire that had been validated from psychological studies on cynicism, and when they administered that to seniors, they showed that the patients the participants who had the highest levels of cynical distrust as measured by this questionnaire were more likely to develop dementia. And depending on which model they looked at, this was a 2-fold to 3-fold higher likelihood of developing dementia just from cynicism. And so when you see all the terrible things that are happening on the news and that you're seeing in your social media feed, it's important to take a break and step back from that cynicism if you want to put time on your side in terms of reducing the risk of developing dementia. Sixth lesson, this is something Dr. Beattie mentioned already, stay productive. This is a quite famous study. It's now almost 20 years old, and the data are 30 years old, but Scandinavia has a very good public health systems, much like we hope we have in Canada, where you can keep track of large groups of people because they're all taken care of by the single insurer, which is the state. And so they were able to look at a large group of people in Stockholm, and they had information on the amount of mental activity, social activity, and productive activity that they do over the week. And they could show that for all 3 categories, if you do social activity or productive activity on a daily basis, your odds of developing dementia are greatly reduced. So social activity is a little bit challenging right now, although I will come back to some examples of how we can do that during the pandemic. But productive activity can still happen even if you're not social, and so things like gardening or cooking or sewing, knitting, etc. So anything, and this may feed into the sedentary behavior that I was speaking about earlier. Keeping your mind active is really important, although I would say that as of right now, we don't know exactly what the best way to keep your mind active is. There's lots of companies now that have developed brain gym type games. You can get games on a Nintendo Game Boy. You can get computer games, websites that you log in that all claim to boost your brain power by, if you do these particular games every day, and you'll boost your brain power. And this fairly famous study now that is about 10 years old showed that unfortunately doing specific brain games did not seem to really make any improvement in cognitive function other than you got better at that game, but it wasn't generalizable into other cognitive functions. What they did is they got thousands of people who watched a very popular British TV show to sign up for this study, and some of the people were told to just exercise their brain in a non-specific way, so they were given interesting things to research on the internet and take notes on. Others were given very specific brain training exercises, and there was no difference between the two groups in terms of any improvements on any of the psychological tests that they were given online as well. So strategy computer games might even be better than brain training, and there's research being done in this area, but I think right now I would say there's no specific type of training to recommend. So read, but discuss the information that you read as well, because then you know that you're actually manipulating it and processing it and absorbing it. Learn a new language, pick up a musical instrument, attend webinars that are of interest to you. Anything that will keep your mind active is probably good, and it doesn't have to be one specific activity. Take care of your vascular risk factors. And so we, for years, have focused on heart health, and we know that things like high blood pressure, smoking, and diabetes are bad for your heart and they're bad for your physical health, but we now know that they're bad for your cognitive health. And so we can see in that Lancet Commission report that hypertension, smoking, and diabetes contribute to the potentially modifiable portion of the risk of developing dementia. So I put this rhetorical question here. Did you know that smoking is bad for you? And I hope that most people on the webinar here know that. But now you can add dementia to the list of things that smoking contributes to, in addition to heart disease and stroke and cancer. And this fairly famous study out of Finland, the FINGER study, was published 5 years ago, where they tried to combine some of these factors. So they looked at supervised nutritional advice, supervised exercise, examination of those vascular risk factors, so making sure that patients' blood pressures and blood sugars were being monitored, and cognitive training. And they looked at patients who did not have cognitive impairment but may have been at risk of developing cognitive impairment because of a combination of their age and their family history and other medical issues that they had underlying. And the participants who took part in this intensive lifestyle examination had an improvement in cognitive scores over time as compared to the control group. And this was particularly apparent in aspects of executive functioning, which is kind of problem solving and your ability to sort things out in order, aspects of processing speed. And interestingly, it did not have as much of an effect on memory, even though memory is often what people will talk about. So there are other parts of your cognitive abilities that may improve with paying attention to your risk factors. Lesson 9 is getting a good night's sleep. This is a very interesting study where they could measure the amyloid protein. You remember that's that protein that deposits in Alzheimer's disease in the spinal fluid of patients, and show that the proportion of patients who had the amyloid below a certain threshold where we think that it indicates there's underlying Alzheimer's disease was far greater in participants who had decreased sleep efficiency. And again, here there's a chicken and an egg issue in that, is the change in sleep pattern a symptom of the Alzheimer's disease that we had heretofore not recognized, or is it contributing to the Alzheimer's disease? But again, there's a relationship there, and so paying attention to that as a potential risk factor, I think, is something that's important. And the last one I would talk about, which isn't talked about in the Lancet report because it's not a risk factor, but it's really something you can do to tackle many of the risk factors, is meditation. So we can show changes in brain function in people who do as little as 8 weeks of regular meditation. And what they're showing here is on a glucose PET scan, which shows metabolic activity in the brain, you can see an increase in this important area in the frontal lobe over time in patients who have been able to meditate for 8 weeks. And there's lots of mechanisms that are suggested why meditation would be protective against Alzheimer's disease. And so some of them are direct effects on the brain. So it's a kind of brain exercise, effects on the mood. And we already talked about the relationship between mood and dementia, and effects on other risk factors. So you may be bringing your blood pressure down through meditation. Okay. So in the last 10 minutes, I'd just like to review those lessons and think about practical ways that we can apply these during our pandemic times. So I talked about checking your hearing. And so many businesses do offer free hearing screening even during the pandemic. And consider that the sense of hearing becomes even more important as activities shift online and by telephone. And I would say I totally understand that getting used to a hearing aid takes some time. Just like getting used to using a walker, if you need to do it, takes some time, or any adaptation that you don't have to. It's our human nature to resist it. So I'm hoping that just the information that this could help reduce the risk of Alzheimer's will convince those people whose hearing aids are in their drawer, or who haven't put new batteries in them, or who haven't taken the step to get their hearing checked to do so. I would say that most health-related businesses like optometrists and hearing clinics are all following regulations that have been put forward by WorkSafe BC during the pandemic. And so, I wouldn't use the pandemic as the only reason to put off looking at your hearing. This is a time where people are doing more and more cooking at home. And so this might be a time to look at your diet and think about, how can I change my diet to a more brain healthy diet? And so, like I said, if you just Google Canadian Brain Health Food Guide, you'll be able to download the food guide. If you're interested in an application of the food guide, this book, Mindful, is co-authored by Carol Greenwood, who is a researcher in the brain and nutrition, but Dr. Greenwood paired up with a dietitian, and also with several very well-known chefs from Toronto, and made recipes that incorporate the Canadian Brain Health Food Guide. So if you want to say, well, how do I go from these recommendations to actually trying something out, then you can do that. This book's available on paperback and just in e-format. And I have no financial stake in this, and no personal relationship with the authors, but I just applaud them for having had the guts to try this out. So I think it's a fun book to read on, and even just the information in the introduction is quite good. And if you are fortunate enough to maintain your income so that you can try out new recipes and cook at home, then donate to help those who cannot eat well, because there are many people who can't afford to take care of their health right now during the pandemic, and that's a real unfortunate secondary effect of the pandemic in terms of people who have lost their incomes and who have lost access to supports that they previously had. We talked about exercise, and so definitely it's shifting some of that exercise to outdoors. Combining cardiovascular and resistive exercise doesn't mean you have to go into the gym and lift weights, but you can give yourself a stretching routine. There are many kinesiologists who are offering online courses, and you can download boatfuls of videos on YouTube to get exercise routines that you can do at home. And remember that even modest exercise has benefits. So going out for a walk when it's quiet on the street, and we're just very fortunate in BC that even those of us who live in Vancouver are not that far away from open spaces and fresh air, and so there are opportunities for many people to try to exercise in safe ways during the pandemic. But even more, I think everyone can reduce their sedentary behavior. So just because you exercise doesn't mean you're not sedentary, and then just because you don't want to exercise doesn't mean you can't reduce your sedentary behavior. So look for incremental ways to increase your movement. Schedule regular movement breaks for you, even if you want to put a timer on your phone or your stove or whatever it is. If you have the opportunity to have a standing desk or to put your computer, your laptop up on a higher shelf so that you can stand to use the computer, because most of us are spending more time now on the computer during the pandemic. Put the channel changer on another piece of furniture so that if you want to change the channel, you have to get up and take it, and that's an incentive to move a little bit more regularly. And again, I'm just passing on the advice that I got from Dr. Madden, that to try not to sit for more than 30 minutes at a time. And of course, I've broken that rule for you by speaking for more than 30 minutes today, so I'm sorry. A healthy mind and a healthy mind. So try to put away the social media if you find yourself getting stuck on that, and favor real-time chats with friends and family and phone calls. And even though in-person visits are reduced, there is help available if you're feeling anxious and depressed. And a good place to start is the BC division of the Canadian Mental Health Association, where there's a link to several tools, including some online tools. If you're just feeling mildly depressed or mildly anxious, and you don't think you want to look at medication or therapy, but you want some coaching to help you through it, there's some programs offered by the province that can help you through that. And then this website, bc211.ca, is a place where seniors can get connected to volunteers. And there's also family and friend support for caregivers. So if you're a caregiver who's feeling a bit burnt out during the pandemic, as many caregivers are, there are support services available through that resource. Staying productive and keeping your mind active. Dr. Beattie mentioned the wonderful Voices in Motion choir that was started by Professor Deborah Sheets at the University of Victoria. And the choir has shifted online during the pandemic, and I think they're having success as an online choir. And you can go and sign up for one of the choirs online at their website, voicesinmotionchoirs.org. So that's one example of an organization that you can look at, and you can use, again, if you're fortunate enough to have the means, you can use the pandemic as an opportunity to learn how to cook, so you won't just get the benefits of following the brain healthy diet, but you'll get the cognitive benefits of the activity of figuring out new recipes. You can use it as an opportunity to learn how to grow your own food. Maybe this is the time to follow a language course or pick up a musical instrument. And don't neglect your vascular risk factors just because of the pandemic. So do try to check your blood pressure if you have a cuff at home. If you have to go into the pharmacy, then maybe clean the cuff and check the cuff there. If there's someone in your family who can lend you one, just make sure that your blood pressure is under control, that you can check your blood sugar. And if you are a smoker and you think that now's the time to quit, there's good resources at quitnow.ca. Getting a good night's sleep is important, and so remember to do something relaxing for the last 90 minutes before sleep. Set a bedtime and a bedtime routine. Try not to look at screens when you're in bed. Use the bed for what it was meant for, and not for looking at a screen. Try not to take stimulants after lunch if you have trouble sleeping, and avoid alcohol in the evening if you have trouble sleeping. Make sure you're exposed to natural light every day. So even if you're a little bit concerned about the pandemic, go out for a very early morning walk, or so you get a little bit of natural light. And if you have symptoms about sleep apnea, such as snoring a lot or excessive sleepiness during the day, or waking up with headaches in your forehead in the beginning of the day, then maybe speaking to your physician about getting screened for sleep apnea would be a good idea. And then finally, I talked about meditation, and the best way to learn meditation is in a group course, which is of course challenging during a pandemic, but there are many apps online that offer meditation coaching. Many of them have a subscription model, but there are a few ones that are free, and there's so many that I don't really want to recommend one over another, but you can look at Oprah Winfrey had a list of top 10 apps, and I would say Oprah's list is a good place to start, and there's a couple that are free in there. There are online courses, so it's the next second next best thing to being an in-person course is an online course. And this form of meditation, mindfulness-based stress reduction, was developed by Dr. Kabat-Zinn at the University of Massachusetts, and UMass does offer online MBSR courses. And there are reputable instructors who have even put free online courses in an effort to make meditation accessible to people. And I really like this site, PalooziMindfulness.com, where there is an online community that you can chat with for tips. And the clinician who has done this has made all of his courses available for free. So conclusion is that there are normal changes in our brain structure and function with age. And as I mentioned, dementia may represent an extreme of these changes that prevent normal function and is usually thought to be a separate disease. Up to 40% of the risk of developing dementia may be modifiable. So in order to address this, try to think of a brain maintenance program where you can address some of our 10 lessons. And some of those 10 lessons are definitely applicable despite the pandemic. And in some instances, the pandemic to some people may present even new opportunities. So these are apples from our garden that my wife has grown with love that will contribute to our brain health. So thank you very much. I think I've gone right up to the cusp of time, but I am available to stay behind for a few minutes if there's some questions, and then answer some that will come in from the organizers by email later as well.
Thanks, Alex. That was just an amazing presentation with lots of real practical information thrown in. Thank you so much. We are up at tight to 3 o'clock, but I think if we could have time for a couple of questions, if you're able to stay, because I know you have to run, for just a couple, that would be great. Christine, are there two there that we could pull out?
Yes, there are, Maria. The first one is from Poe, and the question is, does practicing yoga replace aerobic exercise?
Yeah, that's a good question. And again, the talk I've given you today is my reading of what other people are doing. And so I don't do research in this area specifically, but my understanding is that there are lots of people looking at whether one specific form of exercise more than the other may be helpful. I think yoga has a lot of aspects of resistive exercise in it. You're stretching your muscle and you're contorting yourself into some areas that are really putting some efforts into your muscles depending on the level of yoga that you do. And it has some aspects of cardiovascular if you're in a more high intensity type of yoga practice. And then yoga has some meditative aspects to it as well. So I think yoga is an excellent activity for people to get into, but I think the jury is still out as to whether it really is the best form compared to anything else. But if you like it and you can encourage people around you to try it out, I think it's a great place to start.
All right, thank you. And this may fall into the same sort of category. The question from Nancy, is anyone, any country looking at improving the technology of hearing aids to make them more acceptable or for ease of use? And how best do you reduce and clear earwax?
Mm-hmm. So the first question is, I'm actually amazed at the new technologies that are already out there in terms of hearing aids, and some are much less obtrusive than even what was on the market 3 or 4 years ago. And it is a high demand sector, and so I think this is an area that industry puts a lot of time into trying to develop better and better models. Unfortunately, they're quite expensive, and that's really one of the barriers that some people have is that especially the newer types of hearing aids that may be less obtrusive are expensive. And so you hope that over time, when the next best thing comes out, then the ones that are the best thing now become a little bit cheaper and more affordable for people. For earwax, last time I spoke to my GP about this issue, it's funny how it's such a common issue, and yet there's no one that's done randomized trials to look at what's the best way to clear out earwax. So there are a number of different methods that all seem to be the same. I think all of the ear, nose, and throat specialists will tell you don't stick Q-tips in your ears. Some people will advocate for a couple drops of mineral oil in the ear. And some people will say just flushing with some water. There are syringes that you can get at the pharmacy that you can safely flush your ear without risking to put it in. They're shaped in a way that you can just flush your ear, and they're not too expensive. So if that's an issue, I would suggest getting one of those. And sometimes you do just need to go to the doctor to get them flushed out properly if you're one of those people who has a significant amount of earwax, no matter how much you try.
Thank you. And we're seeing some comments come in that are offering thanks for the presentation. Maria, do we have time for one more?
Sure, how about one more?
Okay. In the finger study, I wonder if the control group had equivalent attention to as I feel that paying attention to people, greeting by name, etc., is beneficial to dementia and patients' sense of self.
Yeah, absolutely. So in psychology, this is called the dodo bird verdict, which is taken from a passage in Alice in Wonderland, and I won't go through all the details of why it's called that, but basically it says that doing something will always be beneficial to people. And so the finger control group was really a active control group, not just people who were kept on a list somewhere, but they were in the active control group, but they were given education the way we normally give it. So they were given pamphlets and discussed the pamphlets and things, rather than the kind of focused, let's look at your blood pressure. So it's more like, let's have a talk about the importance of blood pressure, but let's not look at yours, for example. There's something called the Finger Consortium now, where they're trying to replicate the findings from the finger study in different settings around the world. And unfortunately, the pandemic has put a monkey wrench in some of those plans, but there is a plan in Canada for a large study called the Thumbs Up, CAN Thumbs Up study, which would be coordinated out of UBC, and my colleague, Dr. Håkon Nygaard at the UBC Center for Alzheimer's and Related Disorders is the principal investigator on that trial. And in the Thumbs Up study, they're going to have sort of a model where they will actually compare two interventions side by side. And when it looks like one is a little bit better than the other, that one drops out and another one comes in. So it would be a stepwise kind of trial over time to just refine which is the best type of lifestyle intervention to give in a kind of a sequential process like that. So I look forward to some news on how or when that trial might get started, making accommodations for the current pandemic.
Thanks, Alex. And again, I think there are just so many great questions that we could throw at you with lots of great answers in return. And it was a very practical presentation, and I know people certainly have appreciated that. And on that note, I would just like to thank you again and Dr. Lynn Beattie for this afternoon. Two really great presentations, really highlighting how clinicians and researchers really have a wonderful way of bringing that information together and bringing it to people and really discussing how we can work together to help people think toward how we can have a dementia-friendly society and support people living with dementia, whether that's worrying about ourselves, our loved ones, people around us, or people in our community. So again, thank you everyone for joining us this afternoon. As with all the other sessions, these are recorded, and so this will be posted on the Dialogue for Aging website for Providence Healthcare. On behalf of the Alzheimer's Society of BC, we are so pleased to partner with Providence Healthcare on this series, as it really is a wonderful way of bringing practitioners to the public and having a really wonderful conversation. The next session in the fall series will be on October 22nd, and it will be Dr. Paul Blackburn speaking, and I believe the title of his presentation is The Fountain of Health. Practical tools for positive mental health. So please register for that when the registration opens, and we would love to see a number of you again. So in the words of Dr. Bonnie Henry, be kind, be calm, be safe, have a good week, and perhaps this week I should also say stay dry, and we look forward to seeing you again in about a month. Take care. Bye-bye.